Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I'll be discussing a very important topic in the connective tissue disorders, that is the sarcoidosis. So sarcoidosis, right, it is a disorder which is characterized by the presence of non-caseating granuloma. And this non-caseating granuloma formation, it occurs in the lungs and as well as the other tissues. Right, primarily it occurs in the lungs and as well as the other tissues. And what are the other conditions where you can have the presence of the non-caseating granuloma? Non-caseating granuloma is seen in ulcerative colitis, right, also seen in ulcerative colitis. All right, and the presence of non-caseating granuloma in the lung, along with this non-caseating granuloma, if there is presence of bilateral hilar lymphadenopathy, right, that is very much suggestive of, or it strongly favors the sarcoidosis. Right, it strongly favors the sarcoidosis. Now in this sarcoidosis, you have the presence of the sarcoid granuloma. Right, you have the presence of the sarcoid granuloma. So this sarcoid granuloma, it is characterized by the formation of the sarcoid granulomas in the various organs. Now what does this sarcoid granuloma contain? This sarcoid granuloma, it contains the giant cells, right, it contains the giant cells within the granulomas, and this particular giant cells, it includes Langerhans giant cell or foreign body variety of the joint cell. Right, the foreign body variety of the joint cells. And this particular sarcoid granuloma, along with this particular giant cells, right, or within the joint cells, you have the presence of the inclusions. Right, you have the presence of the inclusions. And this particular inclusions, we can remember this in the form of a mnemonic, that is SAR. You take this word S, it stands for Schaumann bodies, right, it stands for the Schaumann bodies. The word A is the asteroid bodies. The word R is the residual bodies. All right, so you can just remember this mnemonic SAR, and I'll just talk about these inclusion bodies in detail subsequently, but this particular giant cells contain these inclusion bodies. Okay, now, so in this sarcoidosis, what you have is non-caseating granuloma. Then what are the conditions where you come across the caseating granuloma? Right, what are the conditions where you have the presence of the caseating granuloma? Caseating granuloma is seen in the histoplasmosis, also observed in the tuberculosis, and then the next important condition is the cryptococcus. right? The next important condition is the cryptococcus. So these are the conditions where you have the presence of caseating granuloma, whereas non-caseating granuloma is seen in sarcoidosis and as well as the ulcerative colitis. And if you see the organs which are affected in patients with the sarcoidosis, the question that can be asked is like, what is the most common organ that is affected in sarcoidosis? That will be the lung, right? That will be the lung along with your bilateral hilar lymph nodes. Followed by the lung, the next important structure which is affected is the skin, and that skin involvement will be in the form of the erythema nodosum. I'll show you those images of the erythema nodosum, right? And what is the organ which is least commonly affected? That is the heart. Okay, so the heart involvement, right? The heart involvement is least common, right? Heart is the least common organ which is involved, right? And because of the lung involvement, these patients, they develop respiratory failure, okay? And the respiratory failure, that is one of the cause of death, right? That is one of the cause of the mortality in patients with the sarcoidosis. Whereas you take the cardiac manifestation in sarcoidosis, that will be in the form of the restrictive cardiomyopathy, which I'll be discussing subsequently, right? Then, what are the other causes of mortality apart from the respiratory failure? The other causes of the mortality in patients with sarcoidosis apart from respiratory failure is angioinvasive mycetoma. So, in these patients with sarcoidosis, the individual can get attacked by the Aspergillus niger. See, you should not get confused with the Aspergillus fumigatus. The Aspergillus fumigatus is the one which will cause ABPA, that is allergic bronchopulmonary aspergillosis. But here it is Aspergillus niger. So this Aspergillus niger, it is the one which will cause angioinvasive mycetoma, right? It will cause angioinvasive mycetoma. This angioinvasive mycetoma, even this can cause death in patients with the sarcoidosis, right? And in angioinvasive mycetoma, what could be the cause for the death? Okay, the cause for the death in case of the angioinvasive mycetoma will be due to massive hemoptysis. Right, so this will be due to the massive hemoptysis, that is your Aspergillus niger. Whereas you take these patients with sarcoidosis can also have the sudden cardiac death. Now, what is the reason or mechanism for sudden death in patients with the sarcoidosis? The reason for the sudden death in patients with sarcoidosis, that is due to arrhythmias, right? That is due to arrhythmias, okay? And if the question is asked like what would be the most common cause of death in patients with sarcoidosis, that could be arrhythmias. Now, why there is development of arrhythmias? Because sarcoidosis will contribute to the development of restrictive cardiomyopathy. So where the myocardium becomes completely thickened, and the thickened myocardium is arrhythmogenic, and which will contribute to the development of the arrhythmias causing sudden cardiac death. And if you see the prevalence in the restrictive cardiomyopathy, the prevalence in restrictive cardiomyopathy is that there is increased incidence of sarcoidosis among the blacks than compared to that of the whites, right? And the age at which you come across this sarcoidosis is around 20 to 40 years, right? It is around 20 to 40 years. Now, if you see the etiology of the development of sarcoidosis, or like if you see the etiopathogenesis. So in the etiopathogenesis, you need to understand that there are, or it is caused by two antigens, right? It is caused by the two antigens. And what will be the two antigens? And that two antigens will be Propionibacterium acnes right? Propionibacterium acnes. And in case of Mycobacterium tuberculosis, you have an antigen which can induce this non-caseating granuloma, that is MCAT antigen. So these are the two antigens which will induce the non-caseating granuloma causing sarcoidosis. The pathophysiology is that these two antigens, that is your Propionibacterium acnes and as well as the MCAT antigen, so they are recognized by the antigen presenting cells. So the antigen presenting cells right, so the antigen presenting cells present these two antigens or either of these antigen to CD4 cells in the lymph nodes. Okay, right, these antigen cells present the antigen to CD4 plus T lymphocytes. Right, now what will this CD4 cells in the lymph nodes do? The CD4 cells they produce the two important inflammatory markers. One is gamma interferon, and another important inflammatory marker will be interleukin 2. So you take this gamma interferon. Gamma interferon will be responsible for the granuloma formation. Right, will be responsible for granuloma formation. Whereas the interleukin 2, this interleukin 2, it helps in CD4 cell proliferation. Right, it helps in the CD4 cell proliferation. Okay, now in response to these inflammatory mediators, the macrophages and eosinophils accumulate to form a giant cell. Okay, so now in response to this, macrophages they accumulate to form the giant cells, and along with that, in the granuloma you also have the presence of the eosinophils. Okay, and in this giant cells and eosinophils together they form what is called as non-caseating granuloma. And this, in this non-caseating granuloma, the giant cells will be foreign body giant cell or the Langerhans giant cell. And this particular giant cells, they contain the inclusion bodies or inclusions. They include, number one, the asteroid bodies, and the second one is the Schaumann bodies. So both of them, they are intracytoplasmic bodies. right? Both of them, they are intracytoplasmic bodies. Okay, these are the characteristic features of the giant cells, right? So this is the etiopathogenesis. So you have two pathogens, that is Propionibacterium acnes, and antigen within the Mycobacterium tuberculosis, that is MCAT antigen, right? So they will induce the inflammatory reaction, and that will be sensed by the antigen presenting cells, and they present to the CD4 plus T lymphocytes. They initiate the inflammatory reaction, causing the release of the interferon gamma and as well as the interleukin 2. The interferon gamma, that will be responsible for granuloma formation. Interleukin 2, it helps in the CD4 cell proliferation. And once there is proliferation, right, the macrophages, they accumulate to form the giant cells, along with that eosinophils to form a non-caseating granuloma. And within this giant cell, you have asteroid bodies and Schaumann bodies, which are the intracytoplasmic inclusion bodies. Now, if you see the multi-system involvement, right? Multi-system involvement. So if you see this multi-system involvement, the most common organ that will be affected is the lung. Okay, and this particular lung involvement will be in the form of the interstitial lung disease, right? Most common will be in the form of the interstitial lung disease. Then followed by that, you have the pleural involvement, that will be in the form of the pleural effusion. And this pleural effusion is just seen only in 5% of patients. And cavity formation, it is one of the rare feature in patients with the sarcoidosis. Now, because of this particular lung involvement, what will be the clinical features? Right? The clinical features that you see because of the lung involvement include progressive increase in the cough. So usually it's a dry cough because it is the interstitial lung disease which is seen in patients with sarcoidosis, because wherever you have interstitial involvement, it is dry cough. It is only when alveolar involvement is there, that is a point when you have the cough with expectoration. Then followed by that, you have dyspnea where there is difficulty in breathing on exertion, right? And the next important is the stridor. Now, why is that these patients develop the stridor? Because of the compression of the airway due to bilateral hilar lymphadenopathy, right? Due to compression of the airway by bilateral hilar lymphadenopathy, right? And along with this particular lung pathology, or along with this dyspnea, these patients, they can also have the night sweats. Right, these patients, they also have the night sweats, and they also develop the weight loss. Now, this night sweats, weight loss, then cough, dyspnea, all these, you may misdiagnose the condition as the pulmonary tuberculosis, right? You may misdiagnose the condition as the pulmonary tuberculosis. But what is that which will differentiate the pulmonary tuberculosis from sarcoidosis is the skin involvement. Okay, so the skin manifestation, I'll be discussing that what exactly it is, but the skin manifestation in case of the sarcoidosis will differentiate the pulmonary tuberculosis. Now, because of this bilateral hilar lymphadenopathy, there is like mass effect or compression effect on the surrounding structures. So whenever the hilar lymph nodes are enlarged, they can cause right, they can cause impingement on the airways, right? They can cause impingement on the airways, and because of the impingement on the airways, that will cause the cough, right? That will cause the cough that does not respond to the antitussives. Here the cough is mainly because of your bilateral hilar and hilar lymph node enlargement. And this hilar lymph node enlargement is compressing the airway, because of which there is cough, and this cough will not respond to any form of the antitussives. And this bilateral hilar lymphadenopathy will also cause the compression of recurrent laryngeal nerve. Right, will cause the compression of the recurrent laryngeal nerve. And not only recurrent laryngeal nerve, you also have the compression over the thoracic duct. Okay, now because of the compression over the recurrent laryngeal nerve, that will contribute to the hoarseness of the voice. Right, and because of the compression over the thoracic duct, that will cause chylous ascites, right? That will cause the chylous ascites. So these will be the features because of bilateral hilar lymph node enlargement. Now let me discuss about the skin manifestation. So the skin manifestation in these patients will help us to differentiate sarcoidosis from tuberculosis. And the skin manifestation, we call this as, right, we call this as the lupus pernio, right? And this lupus pernio is observed over the face. And this rash, it is painless. And where do you see this particular rash? This rash is observed over the tip of the nose, right? Also observed over the cheek, right? And this is like butterfly rash. Okay, this is like butterfly rash. And this lupus pernio, what will be the color of this particular rash? It is purple blue, shiny, swollen lesions. Right, purple blue, shiny, swollen lesions. And these lesions, they are observed over the nose, over the cheek, and they are also observed over the lips. Okay, so this is about your skin manifestation, that is in the form of the lupus pernio. Then the next important skin manifestation will be in the form of the erythema nodosum. Erythema nodosum, it is the inflammation of the subcutaneous fat that is observed over the lower limbs. Right, that is observed over the lower limbs. All right, and this erythema nodosum, it is also one of the hypersensitivity reaction that you come across even in tuberculosis. In tuberculosis, you can come across this erythema nodosum, but you don't see the lupus pernio. All right, next. So next to this skin manifestation, in these patients, you need to be aware of one of the variant of sarcoidosis that is called as Lofgren's syndrome. Right, that is called Lofgren syndrome. Now this Lofgren syndrome, it is one of the variant of sarcoidosis. Right, it is one of the variant of sarcoidosis. So in this individual, you have the erythema nodosum, bilateral hilar lymphadenopathy, and there can be also association with, right, associated with arthritis, right, association with arthritis. So this is about your Lofgren syndrome, okay, which is a variant of the sarcoidosis. Then you take the neurological involvement in patients with the sarcoidosis. The neurological involvement in patients with the sarcoidosis, you have the central nervous system involvement and as well as the peripheral nervous system involvement. So if you observe the central nervous system involvement, the central nervous system involvement will be in the form of lymphocytic meningitis, and there is involvement of the cranial nerves. The most common cranial nerve which is affected in case of the sarcoidosis will be the seventh cranial nerve, and it may also involve, right, it may also involve the optic nerve, seventh nerve and followed by that optic nerve, and the optic nerve involvement will be in the form of the optic neuritis, right, will be in the form of optic neuritis, okay. And the next important point is there can be granuloma formation within the posterior pituitary. So because of granuloma formation within the posterior pituitary, right, these individuals will develop central diabetes insipidus. Okay, so neurosarcoidosis will cause central diabetes insipidus where there is decrease in the antidiuretic hormone levels. Okay, then, and this seventh nerve involvement, please remember it is bilateral seventh nerve palsy, and because it is bilateral seventh nerve palsy, these patients, they develop facial diplegia. Right, these patients, they develop facial diplegia, and this facial diplegia, you have many differential diagnoses. What are the differential diagnoses of the facial diplegia? Facial diplegia, it is also seen in the Guillain-Barré syndrome, and facial diplegia, it is also observed in the Lyme disease, right, also observed in the Lyme disease. And you have the peripheral nervous system involvement as well, where the non-caseating granuloma accumulates within the peripheral nerves, resulting in the peripheral neuropathy. Right, resulting in peripheral neuropathy, right. Then, after having discussed about the neurological involvement, you need to be aware of the ocular involvement. The ocular involvement will be in the form of uveitis, right, will be in the form of uveitis, where there is the involvement of iris, ciliary body and choroid, and there can be also pars planitis, right, there can be also pars planitis. So this will be the ocular involvement. Next to this ocular involvement, you need to be very much aware of the involvement of the kidney. Okay, so what will be that renal involvement in patients with sarcoidosis is there will be renal hypercalcemia and joint involvement. Already I have discussed. Joint involvement will be in the form of arthritis, and cardiac involvement already I have discussed, that will be in the form of the restrictive cardiomyopathy. Okay, anyways, let me just include that here again. So cardiac involvement will be in the form of restrictive cardiomyopathy, and these patients can develop the arrhythmias which will cause the sudden cardiac death. And one more important cardiac involvement is that because of the interstitial lung disease, there will be hypoxia, and this particular hypoxia will cause the pulmonary artery vasoconstriction. Once there is pulmonary artery vasoconstriction, that will cause increased afterload, right? That will cause increased afterload on the right ventricle, right? On the right ventricle, causing cor pulmonale, right? Causing cor pulmonale. So this will be the cardiovascular system manifestation. All right. Now, you need to be aware of one important syndrome in patients with sarcoidosis, and that is called Hereford syndrome. Right, that is called the Hereford syndrome. So Hereford syndrome, what all will be the manifestations? Hereford syndrome, in this individual, you have the non-caseating granuloma right, non-caseating granuloma accumulating in the lacrimal glands and as well as the salivary glands. And because of accumulation of non-caseating granuloma within the lacrimal glands and salivary glands, these patients, they develop dry eyes and as well as dry mouth. So that is the reason why this becomes an important differential diagnosis for the Sjogren's syndrome, because even in Sjogren's also, right, you have the same, that is dry eyes and dry mouth. But this particular Sjogren's, it is immune mediated disorder, it's an autoimmune disease, right? But whereas here you have the accumulation of non-caseating granuloma. So there is like lacrimal gland destruction with the non-caseating granuloma. So that is the reason why in these patients you will notice that there is parotid gland enlargement, right? Parotid gland enlargement. Okay, so that is what is called as the Hereford syndrome. Now, how will you diagnose this Hereford syndrome? What will be the investigation of choice? The investigation of choice in case of the Hereford syndrome will be the biopsy, right? You need to take the biopsy of either lacrimal gland or salivary gland, and that will demonstrate the presence of the non-caseating granuloma. Right, that will demonstrate the presence of the non-caseating granuloma. All right. So this is about the clinical features that you come across in patients with the sarcoidosis. So to summarize all the systems, right? So it is a multi-system involvement, right? So if you take this multi-system involvement, one is lung involvement. Along with that, there will be bilateral hilar lymphadenopathy. So lung involvement, right? Lung involvement will be in the form of interstitial lung disease, pleural effusion, but that is less common and very rare will be your sarcoidosis. And bilateral hilar lymphadenopathy can cause the compression of the trachea causing stridor, can cause the compression of recurrent laryngeal nerve causing hoarseness of voice, can cause the compression of the thoracic duct causing chylous ascites. Then followed by that, skin involvement. Skin involvement will be in the form of lupus pernio and as well as the erythema nodosum. Then the least common affected organ will be the heart. So the heart involvement will be in the form of the restrictive cardiomyopathy that can be in the form of restrictive cardiomyopathy and then cor pulmonale. And the most common cause of sudden cardiac death in sarcoidosis is because of your arrhythmias. All right. Then followed by the cardiac involvement, you take the neurological involvement. So neurological involvement, so central nervous system, you have the development of lymphocytic meningitis. Most common cranial nerve will be your bilateral seventh nerve palsy, and then followed by that the optic neuritis will be there. And the other structures which can get affected is the peripheral nerves, where there will be peripheral neuropathy. All right. And there can be also development of central diabetes insipidus. That will be the neurological involvement. And followed by the neurological involvement, you also have involvement of the eye, that is in the form of uveitis and as well as the pars planitis. Then you also have the involvement of the kidney, and that is in the form of the renal hypercalcemia. So in this way, it is a multi-system disorder. The most common organ affected will be lung, least common organ affected will be the heart. Now you see the workup in these patients, that is the investigations. So investigations in these patients, if you observe or notice, one is blood investigation. The blood investigation, it will show you that there is leukopenia, right? Because your CD4 plus T lymphocytes are utilized in the formation of the non-caseating granuloma. Macrophages are utilized, right? The reason why there will be leukopenia. And because it's an inflammatory disorder, the ESR will be elevated. And if you take the electrolyte abnormalities, these patients, they develop hypercalcemia, and that will contribute to the hypercalciuria as well. Even within the urine, there will be increase in the calcium. Now, what is the reason for the hypercalcemia? The reason for the hypercalcemia is that non-caseating granuloma, that will be releasing the vitamin D. And the vitamin D will cause the calcium absorption, causing the hypercalcemia. And in active cases of sarcoidosis, right, in active cases of sarcoidosis, even the levels of ACE will be increased. Even the angiotensin converting enzyme levels are elevated in 40 to 80% of patients with the active disease, right? And this finding is neither sensitive nor specific enough to have the diagnostic significance. But just remember, the ACE levels are elevated. And the next important is the chest X-ray. Right? The next important is the chest X-ray. So almost 90% of the patients, they have the abnormal chest X-ray, right? And that abnormality will be in the form of, number one, the interstitial lung disease, right? And then pleural effusion. But this pleural effusion is the rare entity or the rare manifestation. Then the hallmark feature will be bilateral hilar lymphadenopathy, right? Bilateral hilar lymphadenopathy. So that will be the hallmark features in the chest X-ray. I'll show you the chest X-ray as well. And within this particular chest X-ray, there are three patterns. So first of all, observe this. Yes. So this is what is your bilateral hilar lymphadenopathy, right? This will be your bilateral hilar lymphadenopathy. And three classical X-ray patterns of pulmonary sarcoidosis are, so you take type 1. In type 1, there will be bilateral hilar lymphadenopathy. Along with the bilateral hilar lymphadenopathy, there is no parenchymal changes. So parenchymal involvement is absent in cases of the type 1. And you take type 2. In type 2, along with bilateral hilar lymphadenopathy, there will be diffuse parenchymal changes. And whereas in type 3, you have only diffuse parenchymal changes right? You have only diffuse parenchymal changes, but hilar lymphadenopathy is not there. Right? There is no hilar lymphadenopathy. So this is what is your type 3 pattern of the chest x-ray in case of the pulmonary sarcoidosis. And in the chest x-ray, you need to remember one important triad, and that particular triad is the Garland's triad. So what is this Garland's triad? This Garland's triad, it is also called as 1, 2, 3 sign, or this is also called as the pawnbroker sign. Right? It is also called the pawnbroker sign. So here in these individuals, there will be bilateral, right? There will be bilateral hilar lymphadenopathy. Along with that, there will be right paratracheal node enlargement. Right? There will be paratracheal node. So this will be your right paratracheal node enlargement. Right? And this will be your bilateral hilar lymphadenopathy. Right? This will be your bilateral hilar lymphadenopathy. So this is what is called as the Garland's triad, also known as 1, 2, 3 sign, also called as the pawnbroker sign. Alright? Then, now, after having discussed about the chest x-ray part, the next is the inflammatory cells. What will happen to the CD4 to the CD8 ratio? Whenever there is active sarcoidosis, that will result in exaggerated immune response, resulting in accumulation of large number of CD4 plus T lymphocytes. But where? In the organs, not in the peripheral blood. Okay. So within the organs, if you observe, the ratio will be 10:1. Right? Within the affected organs, the ratio will be as high as 10:1. So you have to remember that the CD4 to CD8 ratio, whatever is there, it is not in the blood. Right? The CD4 to CD8 ratio, whichever is increased, it is not in the blood. Okay? It is in the affected organs. Right? Then, next to this CD4 to CD8 ratio, then we have the gallium uptake studies. Right? We have gallium uptake studies. So these are the radionuclide studies, that is gallium 67 uptake. So this gallium 67 uptake, this will give rise to the two important signs. So wherever there is non-caseating So wherever there is non-caseating granuloma, there is excessive gallium 67 uptake, and that will result in the two important signs. One is lambda sign, and the other one is the panda sign. So you take the lambda sign. Lambda sign is that where there will be bilateral hilar lymph node enlargement, right? Along with that, there will be right paratracheal lymph node enlargement. So this will give rise to lambda sign. The next what we have is the panda sign. So if you take this panda sign, it is increased gallium 67 uptake within the parotid glands and as well as the lacrimal glands. So this is what is your lambda and as well as the panda sign. Okay, so this is a highly specific pattern for sarcoidosis. But ultimately, what is the investigation of choice? Investigation of choice will be the biopsy. Now, what does this biopsy contain? This biopsy, it contains the presence of non-caseating granuloma. All right. Then, okay, what does this non-caseating granuloma contains? It contains giant cells, that is Langerhans giant cell or foreign body giant cell. And along with that, you have the presence of inclusion bodies, that is sarcoidosis, asteroid bodies, and then residual bodies. Then followed by that, you take the pulmonary function test in these patients. Because the individual is developing the interstitial lung disease, so it's a form of, right, it's a form of restrictive lung disease. Right, it's a form of restrictive lung disease. Now, because it's a restrictive lung disease, right, because it's a restrictive lung disease, if you take FEV1 by FVC will be less than 70% and you take the DLCO will be reduced, that is diffusion capacity of the lung. I'm very sorry. FEV1 by FVC will be more than or equal to 70%. DLCO, that is diffusion capacity of the lung for carbon monoxide, will be decreased. And what will happen to total lung capacity? Decreases. What will happen to your residual volume? Decreases. What will happen to your functional residual capacity? Decreases. So this is what the pulmonary function test shows in case of the sarcoidosis because of interstitial lung disease. And we have a good olden test that is called Queem-Silsbach test. So this Queem-Silsbach test right, this Queem-Silsbach test, it is not being done in the recent days. Okay, so previously when the investigations were not fully developed, then we were using this Queem-Silsbach test. So it's actually a test where you will derive the splenic tissue of a patient who is suffering with sarcoidosis. Okay, so in a patient with sarcoidosis, right? You need to take the splenic extract, and this splenic extract that has to be injected intradermally. Right, that has to be injected intradermally into the patient in whom you are suspecting sarcoidosis. Right, in a patient in whom you are suspecting sarcoidosis, you need to inject this intradermally. Right, now after injecting intradermally, you need to take the biopsy after 4 to 6 weeks. Right, you need to take the biopsy after 4 to 6 weeks, and the presence of non-caseating granuloma right, the presence of the non-caseating granuloma in the biopsy, right? That means you have injected intradermally, and from that intradermal area, you need to take the biopsy. The presence of the non-caseating granuloma in the biopsy specimen, that is suggestive of or highly specific for sarcoidosis. Okay, so this is about your Queen-Silsbach test. So these are all the investigations. So blood investigation, where you have leukopenia and raised ESR. There will be raised ACE levels and there will be increase in the calcium levels. And very important investigation is the chest X-ray, where you have the presence of bilateral hilar lymphadenopathy and interstitial pattern of the lung disease. And you have 3 patterns, 1, 2, 3. You have a Garland striatum, which is also called 1, 2, 3 sign, which is also called pawnbroker sign, where there is enlargement of the 2 hilar lymph nodes and right paratracheal lymph node. CD4 to CD8 ratio, that is increased. Queen-Silsbach test, that is splenic extract. Gallium-67 uptake studies, that is lambda sign and as well as the panda sign. The biopsy is the investigation of choice, which will show you the presence of non-caseating granuloma, right? Now, so after having discussed about the investigations, you need to know the treatment. So if you see the treatment of sarcoidosis, see, it is a disorder which is occurring because of the immune hyperreactivity. So the drug of choice will be the corticosteroids. Right, the drug of choice will be the corticosteroids. And within this corticosteroid, the drug that we give is prednisolone. And this prednisolone, it should be given in a dosage of 0.5 to 1 milligram per kg body weight. Right, 1 milligram per kg body weight. Now, what exactly are the indications? Right, what exactly are the indications for the sarcoidosis? The indications for the sarcoidosis, that includes, number 1, the development of hypercalcemia. Number 2, the development of the iritis. Then uveitis. Then arthritis. Next, involvement of CNS, central nervous system, in the form of lymphocytic meningitis. Then the presence of the cutaneous lesions. And what should be that cutaneous lesions? Usually that will be in the form of the lupus pernio, right? And the presence of the pulmonary lesions. Okay, so these are the indications when you need to start the steroids, right? And once you start steroids, you know, these patients, they require the long-term therapy. they require the steroids for almost months to years. Right? They require the steroids for almost months to years. Now, those individuals who are corticosteroid refractory disease, right? In steroid refractory disease, you need to give the alternative immunosuppressive medications. The alternative immunosuppressive medications include methotrexate, next azathioprine, next infliximab, so these are the drugs which are given in the corticosteroid refractory disease. So either of these should be given, methotrexate, azathioprine or infliximab. This should be given in those individuals who are intolerant to corticosteroids, right? Or who have steroid refractory disease. In them you need to give this immunosuppressive drugs. Okay. Then how will be the prognosis in these patients? So if you observe the prognosis, it all depends upon right, it all depends upon the severity of the involvement. Okay. The outlook is best for patients with hilar lymphadenopathy alone. Okay. So there will be best prognosis, or there will be good prognosis if there is hilar lymphadenopathy alone. Right? If there is hilar lymphadenopathy alone, then the prognosis is good. Right? And if there is radiographic involvement of the chest X-ray showing that there is also lung parenchyma involvement, then it is considered to be the individual with right, it is considered to be the individual with the worst prognosis. Whereas another important dermatological complications like erythema nodosum. Erythema nodosum, these patients, they tend to have a good outcome. Right? They tend to have the good outcome. Okay. And this pulmonary complications, that is lung parenchyma involvement, about 20% of the patients with lung involvement, they suffer with irreversible lung impairment. Right? And that irreversible lung involvement, that will be in the form of the interstitial lung disease. That will be in the form of the fibrosis. And that will be in the form of the bronchiectasis. And finally, cavitation. Right? Finally, the cavitation. So these will be the pulmonary complications. Right? As the disease advances, right? As the disease advances, that is lung pathology advances, these patients, they go into a state of respiratory failure, and there can be hemoptysis, and there can be lung cavity formation with mycetoma. So mycetoma formation within the lung cavity, right? So which will be nothing but the aspergillus involvement. Okay, right? So in advanced cases, what would be the cause of death? That is the respiratory failure, right? So, and even the other complication that can be seen is development of pneumothorax. So these are all the respiratory complications that you see in patients with the sarcoidosis. Then followed by the respiratory involvement, you need to be very much aware of the cardiac complications. The cardiac complications, that will be myocardial sarcoidosis. The myocardial sarcoidosis, that will lead to the development of the restrictive cardiomyopathy, that will lead to the development of the arrhythmias, and there can be also conduction abnormality. Right, there can be also conduction abnormality. So this will be the cardiac complications. So these patients with sarcoidosis, they require the long-term follow-up, right? At a minimum, every year, once they have to undergo pulmonary function tests, chemistry panel, that is your ESR, serum calcium and ACE levels, ophthalmic evaluation to rule out your involvement of uvea and planitis, chest x-ray to look for the hilar lymph node and as well as lung involvement, ECG to look for the presence of any arrhythmias. So this is what is the long-term follow-up these patients have to undergo. So this completes the discussion of your sarcoidosis. So let me just quickly recap. It's a disorder which is characterized by non-caseating granuloma. The other condition where you have non-caseating granuloma is ulcerative colitis. So the presence of non-caseating granuloma along with bilateral hilar lymphadenopathy strongly favors the diagnosis of sarcoidosis, right? And in this sarcoid granuloma, you have this sarcoid granuloma in the various organs, which contains the Langerhans giant cell or the foreign body giant cells. And this particular giant cells contain the inclusion bodies, that is Schaumann bodies, the asteroid bodies, and as well as the residual bodies. And the caseating granuloma is also observed in this. What I mean to say is sarcoidosis is non-caseating granuloma. But caseating granuloma, the conditions where you come across is histoplasmosis, tuberculosis, and cryptococcosis. The most common organ affected is lung, that will be in the form of interstitial lung disease. Cardiac involvement can be there, that is least common, that will be in the form of restrictive cardiomyopathy. Finally, the cause of death is the respiratory failure. The cause of sudden cardiac death will be arrhythmias, angioinvasive mycetoma, secondary to Aspergillus niger, that will cause massive hemoptysis causing death. So usually it is common around the age group of 20 to 40 years. In the etiopathogenesis, it is mainly caused by two important antigens, that is Propionibacterium acnes and then MCAT antigen of the Mycobacterium tuberculosis, right? And the antigen presenting cells present these antigens to CD4 cells in the lymph node, and these CD4 cells produce the gamma interferon and as well as the interleukin 2, and that will be responsible for the formation of non-caseating granuloma. Multi-system involvement. Lung, the most common organ, that will be in the form of interstitial lung disease, pleural effusion, and as well as rarely cavity formation, and because of which there will be like cough, dyspnea on exertion, and then hilar lymphadenopathy, and they also have night sweats and weight loss, and this will make a slightly confusion with the pulmonary tuberculosis, but the skin involvement will differentiate pulmonary tuberculosis from sarcoidosis. And this hilar lymphadenopathy can cause the impingement or compression of the trachea causing stridor, impingement on recurrent laryngeal nerve causing hoarseness of voice, then impingement on the thoracic duct causing chylous ascites. Skin involvement will be in the form of the lupus pernio, that is a rash over the face, and it is painless, and it is like butterfly rash. Erythema nodosum is another important skin manifestation. You have a variant of sarcoidosis that is called Lofgren syndrome, where there is erythema nodosum, arthritis, and then hilar lymphadenopathy, bilateral. CNS involvement will be in the form of lymphocytic meningitis, seventh nerve involvement bilateral, there is facial diplegia, optic neuritis, and there is granuloma that will damage the posterior pituitary leading to central diabetes insipidus, right? Then ocular involvement will be in the form of uveitis and as well as the pars planitis. And you have what is called uveoparotid syndrome, which is also called the Hereford syndrome. Where there is non-caseating granuloma within the lacrimal gland and parotid gland, that will be causing dry eyes and as well as dry mouth, right? Then the investigations, if you see, blood investigation in the form of leukopenia, elevated ESR, hypercalcemia, and then increase in the ACE levels. Chest X-ray, you have 90% the pulmonary involvement. That will be in the form of interstitial lung disease. Cavity formation is rare. And along with this interstitial lung disease, if there is bilateral hilar lymphadenopathy, that is very much suggestive of pulmonary sarcoidosis. And you have three patterns in the chest X-ray. Type 1, bilateral hilar lymphadenopathy with no parenchymal changes. Type 2, bilateral hilar lymphadenopathy with diffuse parenchymal changes. Type 3, diffuse parenchymal changes with no hilar lymphadenopathy. And you have what is called Garland's triad, or the pawnbroker sign, or 1, 2, 3 sign, where there is right paratracheal lymph node enlargement, right hilar, and as well as left hilar lymph node involvement. And if you take CD4 to CD8 ratio, that will be elevated within the organs, not in the peripheral blood. And if you take the test, Queen-Silsbach test, that is splenic extract, gallium-67 uptake studies shows the lambda sign and as well as the panda sign. And the biopsy is the investigation of choice, which will show you the presence of non-caseating granuloma. The drug of choice will be the oral steroids, that is prednisolone. And prednisolone should be given in those individuals with the hypercalcemia, iritis, uveitis, arthritis, central nervous system involvement, cardiac involvement, and then cutaneous lesions. Long-term therapy is required. And in refractory cases, you need to give immunosuppressive medications, that is methotrexate or azathioprine or infliximab. So this should be given in those individuals who are intolerant to steroids. And if you take the prognosis, if there is hilar lymphadenopathy alone, the prognosis is good. But if there is lung parenchymal involvement, the worst prognosis. Erythema nodosum, again, they have good prognosis. And the pulmonary complications that can be seen is fibrosis of the lung, bronchiectasis, very rarely cavity formation. And as the disease advances, these patients can develop respiratory failure. The cardiac complications will be in the form of restrictive cardiomyopathy, cardiac dysrhythmias, and conduction disturbances. So these patients, they require the long-term follow-up, right? Where they need to undergo pulmonary function test yearly, physical examination, chemistry panel, ophthalmic evaluation, chest X-ray, and ECG. So this completes the discussion of this very important topic, that is sarcoidosis. Thank you very much.